Before we get started, I have a quick favor. I've been self-funding the Finding Genius podcast for 5 years now. I've done over 3,000 episodes. And as you can see on YouTube, we're up over 1 million views on the channel, which is fantastic. The next thing I really want to push on is to get up to 10,000 subscribers. Because once we do, we'll be able to put a donate button and we'll be able to solicit donations to help keep the podcast running and to also get the Finding Genius Foundation moving along. We have a big project studying anxiety, depression, and PTSD and working on a product to help people overcome these problems because I've seen them explode recently after the last 2 years of the whole virus situation. So if you would, please subscribe to the podcast. That would help us tremendously. Give us a thumbs up and check in the description for Buy Me a Coffee. It's about $5. If you could buy me a coffee, I'd really appreciate it. It would help keep the channel going, and I love coffee. Thank you.
Hello, I'm Alan Breen, Emeritus Professor of Musculoskeletal Research in the Health Sciences University in Bournemouth, in England. I'm also a visiting professor in the Faculty of Science and Technology at Bournemouth University. I'm going to tell you about a technology called quantitative fluoroscopy, or QF. Its purpose is the investigation of mechanical disorders of the joints, especially the spinal ones. And its use is to help us to better understand the role of mechanics in spinal pain. My story covers the invention, the development, and the use of QF in research and clinical practice. And I'm looking forward to sharing it with you.
Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. My guest is Alan Breen. He's an emeritus professor at Health Sciences University, Bournemouth, and a visiting professor in the Faculty of Science and Technology at Bournemouth University. Hopefully I pronounced it right. We're going to talk about motion analysis and musculoskeletal modeling and the treatment of spinal disorders. So welcome, Alan. Thanks for coming.
Thank you. Thanks for having me.
Yeah, if you would, tell me a little bit about how you got into this field. What attracted you to it?
Well, basically, I was a junior lecturer at the Chiropractic College in Bournemouth in England, and I was doing a fair amount of research as well as teaching. And the college said, well, you should get more involved in research and help us to get our faculty involved in doing PhDs, which scared me. So I tried, and we did all that. And there turned out to be one PhD which was nobody wanted. And that was this PhD about measuring intervertebral motion using, well, at the time, cine radiography, which I can tell you about, or in the end, video fluoroscopy. So I did it.
Why did people want to study intervertebral motion?
That's a really good question. To understand better the role of intervertebral dynamics in spinal pain, because people like surgeons, chiropractors, osteopaths, physiotherapists have always got the idea often that there's something mechanical about back pain, but they can't put their finger on what, which is because they can't measure intervertebral mechanics. So there's a real need to be able to do that, and that's what brought me to it.
Okay. So you said no one wanted to do this, and then what happened next?
Well, the reason nobody wanted to do it is because when I showed them what was involved, they thought it would be a recipe for madness because it involved making marks on a computer screen thousands and thousands of times. That's why people didn't want to do it. It wasn't for lack of interest. It was pure fear of the size of the task.
Oh, back then the task had to be manual.
Exactly.
And just unbelievable drudgery to do that. And if you had an error probably of like maybe a tenth of a millimeter, the whole thing maybe could be skewed wrong, right?
Very often you'd have to go back all the way back to the beginning again. They came from a very primitive technology, which was cine radiography, which is a cine camera, not an image intensifier, a fluoroscopic bit of screen that you use for barium enemas, and not an image intensifier again. And basically very poor images. You couldn't even see the lumbar spine, the lower back. You could only do the neck. So all kinds of hurdles to overcome and to transfer that onto a computer method. And this is when computers were only just getting going. This was the 70s.
Okay. So drudgery of a task. So did you take it up or what happened?
I did. I went to Southampton University and said, look, is this something that can be done? And this is the Faculty of Applied Science and Engineering. They said, yes, you need computers. You need to use a computer method. and skip this motion X-ray cine film thing. So I got into that and found out what was required was a computer image processor and a proper video fluoroscopy unit, C-arm X-ray machine that had a proper image intensifier on it. And from that, I discovered that it probably would be possible. So they said, would you like to do a PhD as a feasibility to study to see if you can actually invent this device? So that was where I got into it.
So is there a particular device today that does this vertebral motion analysis and looks at the dynamics of vertebrae movement?
There's several of them. There was one which is in our lab, which is closed down now, but there are others all around the world now that have sprung up from that. There's certainly some in the United States, there's some in China, there's one in Maastricht, there's one in Cardiff, there's one in Birmingham, but they're all being used for research. I think ours was the only one that was used for patient analysis because research is the most demanding thing that we really need more research to make this slick.
So what are some of the learnings from the research already conducted on it?
Well, first of all, in order to do it at all, you had to invent a method to automatically track the continuous motion of vertebral images. And you had to also invent a method to standardize and regulate the motion of the body while you're collecting the data. So we had to do that first. And then we had to get international patents and look for a commercial partner to commercialize it in partnership with my institution. And then you ask what research we needed to do to develop the technology. Have you heard of technology readiness levels, TRLs?
No, what is that?
Well, technology readiness levels tells you how ready your technology is to be launched onto the marketplace. And there's 8 levels. And unless your technology is around level 6 or 7, it's going to be far too difficult to launch it onto the marketplace and still operate it, sustain it. So our technology needed to go up to level 6, which it's at now, but not right across the world.
What does the level mean? Like, what did you have to do? Any tidbits, to describe what it means to get to this level?
Well, there's the amount of user interaction. If there's a lot of user interaction, it's going to take much more time and it's going to be economically unsustainable to actually use. You need to meet regulatory requirements such as radiation dose. And you have to also meet other regulatory requirements along the lines of the standard of your equipment. For example, you can't use an old fluoroscope. You've got to use one with automatic dose regulation and fast processing and distortion correction and all these other technical things that go along with X-ray machines and image intensifiers. If you haven't got those, you're not ready to launch this on the marketplace.
Okay, so the ones that are, again, being used in research, what are they discovering so far?
I think we've done almost all of the research that's discovered things. So far, to start with, we needed to establish the reliability and validity and accuracy of what we were measuring. We had to decide what to measure. We had to decide how to deal with poor images in people who were, say, obese or had osteoporosis, or there was bowel gas floating across the image, or the image was out of plane. All of these things, we had to decide where we were going to draw the line with what kind of patient, what kind of images we would accept. We had to design graphic user interface, a GUI, with which the user could actually cut through all the technical nonsense of handling data, and it would just be presented for us using a thing called MATLAB, which is a program for handling mathematical information. So that it would work quickly. And this is another requirement for a high technology readiness level. So all of these things had to be done in a research basis and published as well before we could launch it onto the market or even do research with it.
Right, but again, what have been some of the learnings? What are some of the intervertebral dynamics that accompany normal motion, maybe auto accident motion? What did you learn?
Okay, well, first of all, the most important thing to start off with is to establish what normal is and what you're going to measure in terms of normal. Now, in the field, which is orthopedics and biomechanics, the favorite thing to measure is intervertebral rotation, which means tilting. And the second most favorite thing is sliding. Now, those things are highly variable in normal populations, which means that if the range of normal is very wide, then almost everybody's going to be normal, even if they have got pain of some kind. So you have to find a better index than this range of motion, which is the favorite in the orthopedic field, and it still is. So we needed to find a better variable than range of motion. And we wound up with a variable that was very consistent, and that was motion sharing. In other words, proportional motion, what the people in the field now sort of call motion styles. which is not a very good term. I don't like it at all. But that we'll ignore that term for the moment and just stay with proportional motion, because that's where most of the discoveries have been made.
Okay. So range of motion is not a good indicator of what? Of spinal health, or of what kind of health metrics?
It doesn't correlate with having back pain, simply that.
So what has been observed then when people get into, let's say, a car accident, and they feel like they have whiplash or they're having some kind of pain now? What will you see in the imaging?
Well, you may see, you may have a normal QF report. Can I tell you a quick story?
Sure, yeah.
Well, this is a story about a patient. We'll call her Maria. That's not her name. But she was a patient who was a keen marathon runner. And when she was running a marathon once, she had extreme pain in her back and was taken to hospital, had x-rays, and they discovered that the little bits at the back of the lowest vertebra in her spine had broken and her vertebra had slid forward. It's called a spondylolisthesis. So the surgeon screwed that back together with bone screws. And she recovered over a couple of weeks and went on her way. And then about 2 years later, doing another marathon, she got extreme pain again. And when the x-ray, they found that these bone screws had broken, and you can't remove them once they're broken. So this time, the same surgeon did a massive fusion with big screws, long rods, and an artificial disc which goes in through the front, which damaged her internal organs to some extent. So already we were in serious territory, but she did recover. And then a couple of years later, just during a normal bend, she got severe back pain again. And they x-rayed her and didn't find anything, but the suspicion was that the fusion had come loose. Now, the only way to find out if that fusion really has come loose is to operate again and wiggle the spine through an incision, which is just unthinkable, or to do a QF investigation, because that will detect whether there's motion or not at the fusion site. So they sent her to us, and we did the QF. Lying down, standing up, left, right, forward, back, and we found that the fused segment was well fused and didn't move at all. We found that she had funny movements in the segments above. They moved backwards sometimes. But the main result that they wanted to know is that fusion fused, or do we have to operate again? Because we don't want to.
Did a fusion on her, or what? Or was this there naturally?
No, because the fusion was solid, they decided not to. And when she got the news that her fusion was solid, she was so overjoyed that she recovered within 2 weeks, almost completely.
What do you mean? Why was that good if it was a solid fusion?
Because the segment was stabilized. The whole point of the operations were to stabilize the segment so they didn't slide around anymore. So the problem that they were looking for was instability because of the fracture. And they had stabilized it, and then the problem was, has it stayed stable? And the answer was yes. And that was such good news that the patient felt more hopeful and recovered on her own over the following 2 weeks and has been okay ever since. And the moral of my story is that very often the best result of a QF investigation is that there's no abnormality to find. And that's a lot of the time what we do find. So people have, say, a whiplash accident, as you were saying, and they come and the people are looking for instability in the neck, right, as a result of the accident. Now, if you don't find instability, that's good news, right? But the patient wants to know, why am I still getting pain? The answer is, there's lots of reasons why you're still getting pain, because spinal pain has many more causes than mechanical ones. And you need to look, your practitioner, your surgeon, or whoever it is, needs to look at these other causes of your pain, rather than going deeper and deeper into mechanical issues that don't exist.
What do you mean mechanical issues that don't exist? I don't understand.
QF has found no abnormality. There's no mechanical problem in the neck, so they don't exist.
Again, someone can still have pain even though there's nothing visible.
Yes, that's right. But the point that I'm making is you don't need to chase at mechanical abnormalities to get rid of the pain. You need to look elsewhere. You need to look at neuroalgia.
What about lax ligaments or
that would be
the cerebrospinal fluid bubbling or being trapped? Or
probably not. That would be very rare. But lax ligaments is something that QF seeks out, and it would find laxity if it was there. So you can rule out lax ligaments.
Well, what lax ligaments meaning just that the ligament is in a distended state and it doesn't pull back to its normal.
That's pretty close. Yeah, that's a good question and a pretty close answer. Laxity is regarded as slackness near the neutral position. That's kind of the orthopedic understanding of laxity. The neutral position, right near the neutral position, if it moves very fast, it's straight away because it's not held together near the neutral position. That hurts. And that's the current definition of laxity. So if you don't find that, you can rule that out. And that is one of the things you'd be looking for in a whiplash injury with QF.
So what happens to a ligament in a whiplash injury? Why does it become lax? Does it get stretched beyond the point of no return, and then it can never function properly in its right range?
That hardly ever happens. A whiplash injury is very seldom an actual injury. You can have an incredibly severe whiplash trauma with no disruption. You get maybe some bleeding around the ligaments, but for the ligaments to actually get broken, the injury would probably be so violent in a car that you would die of the impact and the trauma to your brain as your head bashed forward.
But people have underlying ligament laxity, then they get into a car accident, then they have worse sequela. Is that what happens?
Nope. In most cases of whiplash injury, there's nothing mechanically wrong. What's wrong is that there's maybe some bleeding around the ligaments, a little bit, or there's inflammation that follows that bleeding and that causes pain, or there's a habitual muscle spasm from guarding and that causes pain, or there's continuous tightening up of the muscles to guard something that doesn't need guarding and that causes chronic pain. And then there's the anxiety of all that, which dials up your brain's appreciation of pain, and that increases pain. All those things can be managed and treated without bothering about mechanics at all.
Well, again, why would someone have a lax ligament? What causes that?
That's a good question. Lots of different things. There are genetic causes for lax ligaments. You're born with it. There are lax ligaments as a result of injuries, like you described in whiplash injury, but hardly ever that hardly ever happens in the neck. It happens sometimes in the lower back, or it happens because of degeneration of the discs near the ligaments. And the disc degenerates, it thins, and the whole segment becomes slack, and that causes laxity near the neutral position. So those are causes of lax ligaments.
Okay. I mean, someone going into a car accident with, the condition of the ligaments unknown, maybe in this stretched state to begin with, what happens then versus someone that has a, healthier spine and that gets into a car accident?
Well, generally, if you have stretched ligaments that are in any way inconvenient, you feel it. You get there's more work for the muscles to do, and that causes discomfort. And so you would already have some discomfort from that before you have the car accident. Or maybe not. Maybe the car accident just tipped it into a stretch that was far enough to start pain up. There's all kinds of combinations of that. If you look at, there's a 30-minute overview called New Approaches to Understanding Back Pain. That's in the topic summary. It's a podcast, and it basically tells you all the other causes of low back pain in this case, besides mechanical causes. And you need to be a good clinician and work out which one is prevailing in that particular person in front of you.
But again, what happens if someone's back is in a bad state and then they get into a car accident versus someone that doesn't? What will tend to happen more often?
When you say a bad state, do you mean disc degeneration?
They have disc degeneration, ligament laxity, some kind of problem pre-existing.
Okay, if there is a pre-existing problem, then that might be made worse mechanically, as you say, by the car accident. And if it did, and it was a problem of the ligaments, and isn't necessarily a cause because of the lax ligaments, you would detect the laxity with QF. The other causes, if you're interested, of pain that would be stirred up by a car accident would be degenerate discs that are causing very uneven sharing of motion between the bones and the spine that's already overloading the muscles a bit, but it's not bad enough to bother you. But being disrupted by another injury, it would become enough to make the muscles have to work too hard to be comfortable. And that's now your cause of pain as a result of the car accident, but not injury per se.
Okay, so what, when these instruments are used, not in a research context, but let's say after an auto accident, what can they see? Are there any in use in that way, or it's just still in the research phase as far as you know?
I don't think we have seen anyone in emergency room situation. What we have seen is people who've had accidents of various types, and their pain has not gone away. Instead of recovering in the weeks or months after the accident, their pain has become chronic. And then they begin to wonder, why is my pain chronic? Is it something that's mechanical, or is it inflammatory, or is it muscular, or is it my nervous system is hypersensitive? And that's where you come to QF to find out, is there anything mechanically wrong here? And that's what happens actually with most cases of low back pain. Most low back pain, there's no diagnosis. It's called chronic non-specific low back pain. It's the largest cause of disability in the world. And one of our projects, some of our research was to find out, is there anything that QF could detect that's characteristic of that? that might give you a clue to how to treat it. Well, we found two things which are called biomarkers. So a biomarker is something that you can measure objectively, which correlates with having a condition. And one of them is uneven motion, uneven sharing of motion lying down. So you lie the patients down. If you look at these videos of how the data is collected, there's lying down motion tracking. So if you collect the video of the person lying down and they're in chronic non-specific low back pain, one of these segments is moving too much or too little and taking too little or too much of the share of the motion. That's called a biomarker that correlates with having the condition but doesn't necessarily explain the pain.
If one vertebrae takes up or one area takes up more of the force, yeah, I would think it would wear out, whatever is like inside the joint. Maybe it would pressurize the fluid in that part of the joint more than normal. I don't know what that would do.
Well, you're going right with the theory there, Richard, because the other people who do research into low back pain think that the cause of non-specific low back pain is linked to a loss of pressure inside the disc, because the disc is a ring of cartilage, as you know, with a jelly center. And if the ring of cartilage becomes a bit weak and a bit disrupted, then the pressure inside the disc reduces. When that happens, the fibers begin to break a little bit. Not seriously, but a little bit, and that releases chemicals, which hurt. And the theories now among back pain is that is the main cause of chronic non-specific low back pain. Pain from inflammatory chemicals coming out of the edge of the disc, which are contributing to lower disc pressure. Our theory is that that's reflected in the movement between the vertebrae and is reflected in respect of this uneven motion, which is contributed to by the uneven pressures of the disc at that level. So this is just a theory.
Also, too, I mean, there's innervation, there's nerves, there's blood vessels, there has to be some outlet for the cerebrospinal fluid that no one knows. I mean, all these things happen in and around the joint. So what if there's a compressed nerve between two joint segments, or what if the blood flow is compromised because of the distortion of it?
Those are all different scenarios. The cerebrospinal fluid is way back in the spinal canal, nowhere near it. What did you say, the blood vessels? The blood vessels in the disc are very tiny and only around the outside. But they are very important.
In between segments, the blood vessels innervate that. The holes like the foramen and stuff in the areas of the spine, blood vessel and nerve that go in and out of there, right?
That's right. They're very tiny, and they're only around the few outer rings of the disc. They don't go deep into the disc at all. The center of the disc has got no blood vessels and no nerves. They're all around the very outside. Is your understanding different?
I didn't know that. So do you ever see damage to the blood vessels on the outside, or, again, the nerves? Would that have to go through the entire disc, or does it just sit on the outside?
Just sits on the outside. And the pain that comes from a disc comes from the outside of the disc.
How do you know?
Anatomical research.
Okay, because that's where the nerve is located, so there couldn't be pain manifesting anywhere else.
Exactly.
Does the nerve need to be pressurized by, laying around the disc to a certain degree, and maybe if the pressure is lower at certain points, the nerve caves in at that point and gets crimped? I don't know.
No, the nerves only register pain if they're stretched or compressed. So the other way they register pain is if inflammatory chemicals touch them. And the theory that's prevailing at the moment is that's what happens. So if there is a loss of disc pressure and a degeneration of these outer fibers of the disc, that touches the nerves, stretches them, also subjects them to inflammatory chemicals which fire them off, and that causes pain.
So again, with the lack of pressure, would that cause any, again, cave-ins where the nerve would get pulled in and trapped against the, some outer feature of the disc?
If you're talking about the nerves that go down your legs and those spinal nerves, that's a different matter. That's trapped nerves coming out of the spinal canal. But if you mean the tiny nerves that we were just talking about, then they're nowhere near the cerebrospinal fluid. They don't get trapped. They're invested in between the layers of the disc fibers. They're very tiny. So they're only susceptible to causing pain if they're either stretched, crushed, or bathed in inflammatory fluid.
And you don't see that even, people after an accident, that would pretty much never happen to them.
Only if the accident is very severe and the intersegmental level is badly stretched as a result of the accident, then you get some bleeding there and you get some pain from that, but it would recover.
So what do you think? So when people have spinal pain, low back pain, is it very localized or is it diffuse? And does that tell you anything about the nature of?
It does, yeah. That's another really good question. Chronic low back pain tends to be more diffuse. Pain has been going on for months and years. It tends to be in more than one place, in fact. So if you start out with back pain and then a couple of years later you've still got back pain, it's likely to be more diffuse by then. But acute back pain is likely to be much better localized. That's back pain that's only gone on for a week or two and usually resolves. So yes, good point.
Oh, so the dysfunction spreads. Once an area is compromised, it appears to spread to other areas, and that's why it becomes diffuse?
Yeah, it's because muscles that spread over a larger area get involved, and they become uncomfortable because they run out of oxygen trying to stabilize the area or protect the area or get you into a more comfortable position. They get tired, and that makes pain. So these are reasons why pain in chronic conditions becomes more diffuse.
What do you think the pain, again, comes from? Is it, a buildup of lactic acid? Like, what signals pain to the body? Which nerves is it signaling?
Right. The pain from something like lactic acid, which is what comes into where the muscle pain comes along, that's just basically the muscle running out of oxygen, and it's now full of lactic acid, which stimulates pain fibers. And the pain fibers are the tiny little fibers in the muscle. They're not the big nerves that go down your legs. So the tiny little fibers in the muscle, and they will register pain as a result of the chemical lactic acid.
So is that where most of the pain comes from, or what are some other sources?
Okay, so we've already discussed one source, which is the disc, the outer rings of the disc and the little pain fibers that are there. And so you've got that, and the inflammatory chemicals, wherever they are, will send off pain. Other reason for pain is your nervous system. If you had pain for a long time, your nervous system becomes sensitized to pain. It's called central sensitization, and that's really difficult to get rid of. It's susceptible to your mood. If you get depressed, the pain is much more intense. To recover from it, the treatment is to take very gentle but very regular aerobic exercise, and the pain gradually goes down. That central sensitization pain, which is vested inside the whole nervous system, including the brain, will dissipate if you follow that treatment course.
Okay. What are some other therapies that people can do to help with pain? Like, I don't know, is there any specific motion that would help someone? Massage and then chiropractic, acupuncture, Tai Chi, what do you think?
For low back pain, chronic non-specific low back, their latest evidence is that motion training, movement training, instruction on how to move normally from a physiotherapist or someone like that over a period of time, training in normal movement is more effective than any other treatment like manipulation or manipulation is a very effective treatment. But this is just a bit more effective than that. It's more effective than rest. It's more effective than exercise. So that is the latest. The latest treatment that's been shown to be the most useful for chronic non-specific low back pain is movement training.
What about when someone goes to a surgeon and they fuse, a vertebrae or two, they put a rod in? I would think it causes a whole bunch of sequelae. Like what happens there? Can you observe that on these devices?
Yeah, you're right. A spinal fusion is not a cure. So it's very unusual with the spinal fusion for all the pain to go away. But most of the time, the pain diminishes after a spinal fusion. But so surgeons only tend to do it if a person is really in a bad state and there's nothing else that will seem to help. And a spinal fusion, if it's indicated by all the things that surgeons check on, will probably reduce the pain, but it won't get rid of it completely.
Well, what does it compromise? I mean, there's always trade-offs, I would believe, especially with the surgery. Have you been able to observe those manifestations of trade-offs physically?
When you say trade-offs, can you give me an example?
You're fusing the motion of, a vertebrae or two.
Oh, okay. Yeah.
So,
okay, I think probably
so everything else would have to take up the slack, and under various activities, standing, sitting, etc., there's less compensation ability,
Exactly. Yeah, that's called adjacent segment disease. So you've picked up something that surgeons think about a lot. If you do a one-level fusion, you're going to get the movement of that level transferred up to the next one. It's going to have to take the strain. If you do a two-level fusion, you're going to take the strain of two levels not moving anymore, and that's going to be more difficult for the segment to take. So that's the reason surgeons try not to do a many-level fusion, because the next one up is likely to become strained and painful. Not necessarily agonizing, but uncomfortable. And one of the things that has been done in order to try to avoid that is fusion implants that are slightly flexible, so that there is, instead of having a rigid fusion, not all of the strain is transmitted on. Some of it is kept by the operated segment. Well, that's one approach to it. So yeah, there are sequelae. The other sequelae are sometimes that you get scarring, which encroaches on the spinal canal and compresses nerves, and that's a problem. That causes nerve root pain and has to be reoperated on. Or sometimes, as in our friend Maria, the fusion breaks and comes loose, and then it has to be reoperated on. If you find out for using something like QF that it is now unstable, you have to refuse it, which is a bad news. So that's another circumstance where there are sequelae. In Maria's case, everything was fine. The second fusion worked, and she recovered and was fine.
With this new vertebral device, are you able to pinpoint and diagnose better? Are you able to, versus MRI and X-ray? Like, how much better can you see in what's going on?
Well, this is the only way that you can see mechanical effects, dynamic movement effects on the joints. So it's far better than anything else. MRI can detect movement. Ultrasound can detect movement, but the images are so poorly resolved that you can't measure them. So it really is the gold standard treatment for dynamic movement abnormalities in the spine.
When you were talking about low back pain being a commonality, amongst a lot of people, have you found a sweet spot or an Achilles heel, to mix metaphors, in the low back, where the pain tends to manifest, where the injury tends to happen?
So where are the weak spots? Is that what you're saying?
Yeah, that's a better way to put it, right? Are there natural weak spots in people's spines that as they age, or if they get into an accident, or if they're in some kind of sport and they hurt themselves, that it's going to happen there?
Yeah, the most likely place for something to happen that would cause pain is in the lower two segmental linkages of the spine, the L4-5 and the L5-S1 linkages. And the reason for that is that they're the ones that take the most strain. If you think about it, more of the body's weight goes on those than in any other segment because they're right at the bottom. So there's more pressure goes on them. And that's probably the reason why they're more prone to degenerating, drying out, if you like, thinning, rupturing, herniating.
Oh, and since they're higher pressure than other segments, therefore, if they can't sustain pressure, there'd be more dysfunction because they have a much higher need to have a high pressure. Interesting.
Yeah, that's right.
Have you noticed much distortion in people that are overweight, that have like a lot of belly fat versus not?
No.
What does that do to the spine? And, what have you noticed?
Yeah, there's been a lot of research into the effects of obesity on the incidence of back pain, and there isn't any relationship. You might be pleased to know there's no relationship between obesity and getting back pain.
Yeah, but I mean, some people have, different, some people would have scoliosis, some people would have like a texting neck, like a dowager's hump type arrangement. Some people, they kind of walk, with their back angled backwards or forwards. I mean,
oh yeah, that's nothing.
Common distortions that really affect the, the movement of the spine and pain.
Yeah. So leaving obesity aside, which doesn't count, scoliosis will eventually cause pain if you don't straighten it out with adolescent surgery. And that just basically means you can't stand for long before the pain building up from the stretching of the ligaments, because the spine is not taking the weight axially, it's taking it to the side. The weight's going on the ligaments and straining them. So scoliosis is a good one, as you say. What was the other ones?
Lordosis, kyphosis. Now I remember the names.
No, that's
or if you're on the computer all the time, your head's forward, head carry, that kind of thing.
Yeah, that's absolutely right. That kind of head carriage or a slouched posture will eventually fatigue the muscles, and that will cause pain. And this is the lactate again. So if you get a abnormal balance, in other words, you're tipped forwards. If your discs in your lower back, this is the common problem. If the discs in your lower back thin, then the lower back tilts forward. Can you see what I mean?
Oh, okay.
Yeah, if the discs thin, then the vertebrae is wedged forwards, and then the person tips forward.
I mean, if they thin on the inside, on the stomach side of the spine versus the back side of the spine.
That's right, at the front.
Is that where they tend to do that? Like from slouching, the disc gets compressed towards the front and open in the back?
That's what happens when the discs dry out and degenerate. They get thin because they lose fluid, they lose water, they lose pressure, and the spine tilts forwards. And in order to stop you from tipping forward and falling forward, you got to use your back muscles, and that causes fatigue. So in older people where they're all slouched forward or their head is down, their neck muscles and their back muscles are having to work overtime to compensate for that.
Okay. Makes sense.
Yeah.
Should this device be in clinics to to help car accident victims? Like where should it be instead of just the lab?
The main home for this is an actual surgical department. That's where it's been used the most. It's most important, as in the case of Maria, to have access to this, because the consequences of not doing the right thing are disastrous. If you operated on her again, you might cripple her for good. And if people have a scoliosis, a severe scoliosis, and they've got to have spinal surgery for that, the consequences of getting that wrong mechanically are very serious. And then people who have had disc hernias and have an unstable segment because of a disc hernia, if you choose the wrong segment to operate on, you have a disaster on your hands again. And QF tells you what segment to operate on. So these are all reasons for having these in surgical departments in hospitals. But you can also have them, as in some places in the United States, you can have the image acquisition done in private clinic, a radiology clinic. In the the image is sent to a lab for analysis, and then the surgeons can collect the results from there. So it doesn't have to be in hospitals. It's also very useful to people like chiropractors and physiotherapists who are thinking of referring to surgeons. So do I need to refer this patient to a surgeon because of, say, instability? So if you refer them to a clinic that has a lab that will do QF, you'll get your answer. Private clinics who receive patients from osteopaths, chiropractors, and physios who deal with spinal problems and they seem to have a mechanical component, and you want to know what it is, those clinics would do well to get a QF facility.
So this should be used before any spinal surgery, it looks like, and it probably also should be used in vehicle accidents to see the extent of damage and if surgery is needed, what to do and what not to do to make it, make it better and not worse.
Yeah, if the examination, the case history, and all the other things that these clinicians do add up to a strong suspicion of instability or mechanical disruption, yes, this should be done.
How do you test for the pressure inside a disc? How can you tell? Can you look and somehow calculate it?
Well, you used to be able to do something called discography, which means putting a needle right through the back into the side of the disc and then releasing the barrel of the needles, and there should be pressure in the disc that's measurable on a monitor or on a tube that comes from the syringe into a machine. So this is called discography, and if the disc hurts and the pressure is low, then you have a damaged disc. The trouble is just putting the needle into the disc damages the disc. So that's been rather outlawed as a way of measuring disc pressure, but there's no other way you can do it in a living person without damaging the disc.
Well, why couldn't you using your machine, actually? Using the machine. Well, you can put them in different positions. The disc pressure should increase to accommodate that. I would think, therefore, you can visualize the difference.
Yeah, that's the research we're doing now. So we've discovered that people who have non-specific low back pain have a different movement pattern that suggests the disc pattern, the disc pressure is dropped. The reason we think the disc pressure is dropped is because when you bend the person, there's a rapid acceleration in the tilting right at the beginning of the movement, and then it's normal again. And that rapid acceleration of the tilting, you were talking about, or somebody was talking about modeling. If you use finite element modeling to figure out what that rapid acceleration means, it comes out as it means reduced disc pressure. So the hypothesis is that rapid accelerations in tilting of the vertebra show a mean reduced disc pressure at that level. So it's yet to be proven. There'll have to be a lot more work on it.
What about the fluid mechanics of of what's inside of a joint? Is it compressible mixture? Is it not compressible? And I guess that would inform this. Yeah.
Yeah, liquid is the water is incompressible, so there's that. But are you talking about inside a disc or inside a joint at the back?
Actually, both areas. What are the fluid mechanics of both?
Okay, well, the disc is completely different. If you compress a disc, you'll squeeze the water out of it, and the water goes into that happens when you stand all day. Your discs, you get shorter because the water inside your disc is pushed back into the vertebra and taken away into the bloodstream. Then you go to bed, they swell up again. So that's the way the water is transplanted in between vertebrae in the disc through the bottom and the top of the vertebra on either side. But in the little joints at the back, in a joint where the water bathes the fluidity bathes the sort of lubrication of the joints, that's sealed in. That fluid, the joint fluid, doesn't get out through any surface at all. So if that gets damaged and you lose joint fluid from a little joint at the back, The problem there is lack of lubrication and then wear on the joint surfaces and eventually degradation and breakdown and arthritis.
Well, when you say that discs will dry out, where is the drying out occurring?
It's drying out in the disc. In other words, the water that has left the disc and gone into the vertebra doesn't come back. So the disc is dehydrated and is therefore thinner.
Why would this happen when someone gets older? What's changing to cause the water to not be able to go in and out as it used to?
That's because the cells inside the disc, which are cartilage cells, they only reproduce very slowly. And when you get older, the transport of fluids into the disc is slower, and the disc cells don't get the nutrition that they normally get, and they die. And that degradation and wasting is shown in the disc degeneration because they die off and they just turn to fiber rather than living cartilage cells.
Oh, then there's no passage of water in an hour worth of fiber.
Exactly. Yeah, exactly. Yeah.
Okay, very, very interesting. But what's the best way for people to, get more of a handle on what we were talking about today?
Well, there's two sides to it. There's the clinical practice side, there's the service side of it, and there's the research side. At the moment, I think there's only a few places who are actually doing this to patients. But there's more and more places all over the world that are using it for research. And the reason for the research is to find out how best to use it, which is pretty urgent because there's no point in just doing sort of hit and miss quantitative fluoroscopy exams. But there is a need which is not being fulfilled. There is a need to be able to access quantitative fluoroscopy to find out if there's instability in the spine, which there hardly ever is. But if there is, it needs attention. Or to find out if a fusion has fused, or if it's come loose, or if you need a fusion. But one of the things that surgeons do is to decompress the spine. So if you've got a lot of arthritis encroaching on the spinal canal and trapping nerves, surgeons will operate and snip that away. But if that is responsible for taking some of the essential strain on the spine, and they don't fuse it as well, then you have a catastrophe because you have a very unstable segment. So surgeons need to know whether they should fuse as well as decompress the spinal canal. And the best way to find that out is with QF. And unfortunately, it's not available.
Is there a last question here that just occurred to me? When will there be enough data where you can model the anticipated post-surgery effects of a fusion, of a cutting away of arthritis, etc.?
Okay, there's all kinds of different ways of modeling. You can model motion, or you can model load, and that can be load that's going sideways or downwards. And so there's all kinds of different models that you can use. If you want to model motion against normal, then we have published a normative database of what normal motion looks like. It's publicly available and anybody can get hold of that, and they can put it into the kind of model that they're using for their research. So modeling is mainly for research, not for treatment, because modeling is hypothetical. Something in the model is purely
but if you have before and after actuation videos of a fusion or of, again, a cutting away of arthritis, then you end up with hundreds of thousands or millions of them. That's why it would be so important for this to become a clinical tool.
Yeah.
Because then you can get vast amounts of data and you can radically improve your modeling. You could see if we fuse here and all that based on your spine and the millions of pictures we've seen, the AI says, not here and not there, do this and not that.
That's not what I understand by modeling, but that's fine. That kind of modeling, as you say, you're actually developing what's called phenotypes, which is the particular typology of that condition in mechanical terms. Is that what you mean?
Again, if I need a fusion, I would rather that it's informed by models of, a million images before and after, so that we know with more certainty or more likelihood of what's going to happen to me if I get a certain fusion or if I get certain arthritis cleared, so I don't have a bad outcome later.
Are you talking about research into what happens to people before and after? In lots of people, a database?
Yes. Yep.
Yeah. Well, you'd have to have thousands of QF investigations to build up that kind of a database. What we've done so far is to build up a database of just normal movement, so you know whether your movement is abnormal or not. That's as far as we've gone.
Okay, gotcha. Well, that's for the future. Well, very good, Alan. Thank you for coming on the podcast. We're out of time. And again, what's a central place where people can go to start learning about, these machines and your research?
On to the topic summary that I sent you. At the bottom of that topic summary, there's a list of online resources, and there's 5 different things. They're all websites, and you can get the information from there.
Excellent. That'll be in the show notes. So thank you so much for coming, Alan. I appreciate it.
All right. Thank you. Take care.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.